Good afternoon, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Early Intervention for Eating Disorders, Prevention, Identification, and Referral, presented by Dr. Susanna Kahnke. My name is Kathy Dixon, and I'll be moderating the session today. I will cover a few housekeeping items before we get started. Following the presentation, we'll have time for questions, so please use the Q&A feature in the webinar toolbar to submit your questions, and we'll cover as many as time allows. The webinar will be recorded, and the link will be shared in the follow-up email after the session. Instructions for how to claim credit will be uploaded to the chat section, and I will also send it in the follow-up email after the session. So without further delay, it's my pleasure to introduce our presenter today, Dr. Susanna Kahnke. Dr. Kahnke is a postdoctoral psychology fellow in the Department of Psychiatry who specializes in the treatment of eating disorders in adolescents and young adults. She holds a PhD in counseling psychology. She currently sees patients on an outpatient basis and also provides therapy to individuals in the hospital's partial hospitalization program for eating disorders. She uses a number of evidence-based practices to treat eating disorders, including enhanced cognitive behavior therapy for eating disorders and family-based treatment. She practices from a weight-neutral, anti-diet approach. She will be transitioning to a faculty role as assistant clinical professor in psychiatry next month. So welcome, Dr. Kahnke.
Thank you so much, Kathy. I really appreciate it. And thank you to everyone for being here today. I'm so glad that there was such an interest in this topic. I think eating disorders are something that, unless you seek it out, often you don't get a ton of exposure or training with it. So I just found it really encouraging that this topic was specifically requested and then that so many people signed up for this information today. So thank you all for being here. Like Kathy said, I'm a postdoctoral psychology fellow. Currently, I'll be transitioning into a faculty position as a psychologist here in about a month. So just given that context, right, I'm a psychologist. I'm a mental health professional, so I don't have medical training. So the scope of this presentation is really going to be more the therapy perspective. I have some kind of medical knowledge that I keep to kind of do some psychoeducation with patients about medical complications and things and eating disorders and things like that. But that's really not my scope of practice. So just you're aware of that. Most of my experience with eating disorders is with adolescents and young adults. I really tried my best to keep this presentation broad across age groups and things like that. But that's just kind of where I'm coming from, is I have more experience with adolescents and younger adults. So some of it might skew in that direction. So really quickly, I do not have any disclosures. I did try to pack in quite a bit of information today, so I'm going to do my best to kind of keep it within time so that we still have time for questions as well. But you would have seen these learning objectives already, but we're going to talk about some of the signs and symptoms, prevention strategies, level of care, and referrals. So before we get started, I just want you to think to yourself in your own mind, who do you picture when you think of someone with an eating disorder? Kind of think of just what comes up for you. What's the age of that sort of stereotypical person you're thinking of? What's their gender? Just any pieces of what that person looks like or what comes up for you. So the reason I ask this question is because for most people, and there's no shame in this if this is you, because this is the image that we really have in our culture, but for most people, when we think of eating disorders, we think of what we kind of in the field call the swag stereotype. So it's skinny, white, affluent girl. And that is certainly a very common presentation for eating disorders. However, the reality is that anyone can have an eating disorder. And often when we are operating from that sort of stereotypical view of what someone with an eating disorder looks like, it means that other people can kind of fall through the cracks. And sometimes symptoms can get attributed to other things when there may be an eating disorder going on. So it's just a reminder that while there are some high-risk presentations, I really want us to think broadly about who can have an eating disorder and what eating disorders look like, so that we're casting a wider net and things like that. So with that swag stereotype, just wanted to kind of bust some myths a little bit. Actually, individuals in larger bodies have a greater chance of having eating disorders and that they get diagnosed less often. We're talking more broadly with eating disorders here, so that number would be different if we were just talking about anorexia. But often people with eating disorders are not medically underweight. So something to kind of be aware of as we're working with folks. People of color are also at an increased risk for eating disorders, but again, less likely to receive treatment. When we're looking at the A for affluent, food insecurity is actually a big risk for eating disorders. This is kind of an emerging research area in the field. There's some really interesting stuff going on there, but essentially what we know so far is that both current and historical food insecurity is associated with an increased risk of developing an eating disorder. Now, it's true that eating disorders are still more common in women than in men, but that number is increasing pretty quick for men. And there's some interesting things going on in sort of men's health and a lot of misinformation and disinformation and gym culture and stuff like that, where things might look a little bit different. But those rates are increasing and again, it takes them longer to get recognized. And finally, queer and trans youth also have increased risk of eating disorder. So just think broadly about what eating disorders look like. So I meant to say this at the beginning as well. This is more introductory in terms of eating disorders. So if you're someone that has experience with eating disorders already, there might not be a ton of new stuff in this presentation for you. There might be some, but I am going to go over just diagnoses just briefly because I'm not sure where everyone's coming from. Some common questions that we get is like, what's the difference between anorexia binge purge type and bulimia nervosa? Because sometimes when there's purge behaviors going on, folks just think bulimia. Actually, what it comes down to is body weight. So when there's significant weight loss, when someone's not maintaining their weight, when they're not getting enough energy in their bodies for the amount of energy that they're using, that's anorexia. And there still might be pretty frequent binge or purge behaviors in anorexia, but if they've lost significant amounts of weight, or if they're underweight or undernourished, that's when we're looking at anorexia. Bulimia nervosa is not so much about the weight loss or weight requirements. And bulimia requires both binge and purge behaviors. In anorexia, that binge purge type, you might see either or, but in bulimia nervosa, you need both binge and purge behaviors. Binge eating disorder is a little bit more simple. It's just binge behaviors with the absence of purging and things like that. ARFID is our one that is not body image based, so it actually has in the diagnostic criteria no evidence of body image disturbance versus like anorexia and bulimia, where body image is a diagnostic feature of it. So ARFID is more about food aversions, so difficulty with textures of foods, difficulty with fear of negative consequences of eating, such as like fear of throwing up, is a relatively common one, things like that. Or some people's brains are just wired a little bit differently and they just don't enjoy food as much. So that's ARFID as well. And then some other less typical ones. So atypical anorexia is when someone has all the diagnostic features of anorexia, but they aren't underweight. They're not at like a dangerously low weight, or there hasn't been that really significant weight loss. And then we have bulimia and binge eating disorder of low frequency or limited duration. And finally, purging disorder, which is when there are purge behaviors but no binge behaviors. So just some of the basics there. You'll notice that pica is not here, even though that's technically an eating disorder, as well as rumination disorder. Those are just diagnostically a little bit different and not necessarily within the scope of this presentation today. So eating disorders go undiagnosed and untreated a lot. This study is from the National Institute of Health, and it estimated that only about half of those who meet criteria for an eating disorder sought treatment during their lifetime. There's a lot of reasons for that. Eating disorders are very stigmatized. Often folks who have eating disorders, there's a lot of shame and secrecy around the condition, so they hide it, right? They don't want people to know that this is going on. Also, with certain eating disorders, specifically anorexia, often they don't want to get better, right? That fear of weight gain is really intense. Seeking help would mean often weight restoration, so that's a pretty big motivator to not seek help. And also just a lot of eating disorder behaviors are very normalized in our culture, right? It's, eat less, exercise more, right? And things like that. There's really intense weight bias in our culture. So often those behaviors are normalized, which makes it harder to seek help as well. Again, that swag stereotype and often lack of access to care. So let's talk about some of the risk factors. Here's some of the biological risk factors. So family history is a really big one. There's both the genetic component of it. So there's some strong research that there's a strong genetic component, particularly to anorexia, but there's also the sort of socialization piece of that too, right? If you have, if you're raised by folks who have their own issues with body image and eating and things like that, sometimes that stuff can be socialized into the individual as well. A high body weight in childhood, which I should be clear is really not, from my view, due to the body weight itself, but is due to the experiences of discrimination that come with being in a larger body that can lead to someone identifying or developing an eating disorder. Early start of puberty in girls, that sort of body changing before their peers and bodies kind of looking different before their peers and standing out is at risk for developing an eating disorder. And when we're talking about women specifically, some of the sort of major life changes where the body goes through changes as well can really put one, can be a risky time for some. Gastrointestinal concerns can also, like, they're definitely a symptom of an active eating disorder, but also can sort of put someone at risk of having an eating disorder as well, because, if you take two people who have body image issues, one of them eats just fine without physical complications, and one of them, starts having tummy issues and vomiting or whatever is going on with eating, they might lose weight as a result of that. They might get social reward from that, and it could sort of lead to an eating disorder developing. Similar with dietary restrictions. So you kind of learn how to restrict, you learn how to be rigid with your diet and things like that. So that can put someone at risk as well. Psychologically, we already talked about this, but very logically, right? Experiences of appearance or weight-related bullying. Perfectionism is a big one. Certainly related to body image, right? We're having to have a perfect body and just be perfect in general, but also there's a sort of like perfectionistic quality to engaging with the eating disorder sometimes, where folks will talk about how accomplished they felt at like staying at this perfect calorie number that they had determined for themselves, or weighing out their food to this like specific grams of whatever. There can be that perfectionism within that. Some co-occurring disorders you'll see here: anxiety, social anxiety, OCD, depression, borderline, things like that. Things that tend to come along with eating disorders. Certainly negative self-concept, right, or negative self-esteem, kind of logical, that one. Trauma is a big one. Trauma history is really associated with eating disorders. Eating disorders are often an attempt to cope, and sometimes it's an attempt to cope with trauma, and all of that can, it's an interesting conversation, and it's pretty complex, but history of trauma is very associated. Talked about food insecurity already a little bit, and athletes, eating disorders are not uncommon in athletes. There's that kind of focus on physique and wellness and diet and things like that. And there's a lot of just energy output. Sometimes folks don't even realize they're not eating enough to kind of maintain their energy output and things like that. And then also it's like, life transitions when maybe a high school athlete goes to college and stops competing, and their life changes in those significant ways, that sometimes that's a time where an eating disorder can develop. So things to be aware of. So identifying eating disorders. just important to know that the earlier you catch it, the better. Early intervention really makes a difference. So, and I'm kind of talking a little bit from the perspective of adolescence here, like just the patient being younger in general. But this is also true of just regardless of age, catching an eating disorder early or in the stages of it. So the earlier you catch the eating disorder, the less ingrained the patterns are, right? It's harder to change a behavioral pattern that's been going on for several years than it is to change one that's only been going on for several months. That brain in adolescence too is more neuroplastic, right? So it's just kind of making changes and forming new connections in the brain it just goes a little easier. And if we're talking about younger patients specifically, getting to work with the parents when the parents are on your side, right? Because that's obviously not always quite the case, but when you have parents that are willing to like work with you and say, yep, we gotta do this, we gotta work on this, it's super powerful. And it's makes a big difference versus, you know, when you're working with an adult and you don't have kind of the parents on your side. So here's some signs and symptoms, both physical and psychological. We'll kind of start on the more physical side. So certainly weight loss or gain, but also just weight cycling throughout life, things like that. We talked about gastrointestinal complaints being a risk factor, but they also can be a symptom that an eating disorder is going on. Constipation, different things can happen. Certainly loss of menstrual periods or even just like changes to menstrual periods. So sometimes can just be more irregular, things like that. Abnormal lab findings, if patients talk about being dizzy or fainting, things like that, feeling cold all the time, hair loss, dry skin and brittle nails, right? Those symptoms of like being undernourished. Sleep disturbances, in more advanced anorexia, sometimes you can see that like fine hair develop on the body that's called lanugo. Poor wound healing, difficulty with immune system stuff, and in the case of like purging, and again, this would be more over time where it's been going on for quite a while, but there's damage to teeth and esophagus and things like that. Psychologically, really any preoccupation with all this stuff, right? Food, weight loss, calories, dieting, just if folks are talking about that a lot, things like that. Sometimes people will brag about their eating disorders, right? Oh, I only had a coffee for breakfast and then I didn't eat anything until 3 o'clock, and look how awesome that is, right? And they'll sort of brag about it a little bit and make light of it. Refusal to eat certain foods, so like cutting out certain foods or food groups, things like that, trying different diets, stuff like that. Avoidance of meal times or situations involving food, right? If they always want to hang out, if they only will hang out when it's not like going to out to eat or something like that, things like that. Food rules and rituals. So, I mean, you know, some of them will say, oh, I can't eat after a certain time or things like that. Just different like rigidity and rules and rituals there. Rituals like weighing food, things like that. Certainly withdrawal from friends and interests. Compulsive exercise or overexercise is a really common symptom of eating disorders that isn't talked about as much as some of the other eating disorder behaviors, but it's a really big one and a really common one that sort of need to earn your food, right? And to burn off the food that you ate. Of course, concern with body shape and size, checking behaviors. We're going to talk a little bit about some of these other things a little bit more later. Mood swings, secrecy around food and meals, and also hoarding food. So that can with binge eating disorder specifically, sometimes folks will hoard food in their like private spaces, like rooms or things like that. So yeah, let's talk specifically about what some of the behaviors are. So they kind of fall into these camps here. So we'll start with restriction. So there's this kind of idea that folks with anorexia just stop eating, right? That's obviously not the case. They wouldn't be able to maintain that for super long. Um, they restrict. So they may fast for periods of time. They may only eat one meal a day, right? They may restrict to a certain number of calories. They may restrict their portion sizes heavily. They may just have a very restrictive diet where they're only eating veggies and they're not getting protein and carbs and fats and things like that. So it can look a lot of different ways. It's often a combination of these different things. But people with anorexia still eat. They're just not eating enough, and they're not eating what their body needs. Binge eating. When we think about this behavior, that sense of loss of control is a defining feature, as well as just unreasonably large amount of food in a discrete period of time. It's helpful to differentiate between subjective and objective binges. Sometimes a patient will say to me, oh, I binged last night. And I'm like, okay, what do you mean? And then they tell me everything they ate, and it's just more of a normal meal because they're quite a restricted individual. And so to them, that was a binge because there's that loss of control, and it's more than they're used to eating at this point. When in reality, it was just like the size of a normal meal. So we'd call that more of a subjective binge. Purging can look a lot of different ways. So self-induced vomiting is the most common one, but laxative use is also pretty common as well. And I think that is one that often carries sometimes even more shame, I think, than self-induced vomiting can. So something that people aren't going to tell you about generally unless you ask them. But also diet pills, diuretics, enemas, things like that. Yeah. And again, like some of these, it's like not even really doing anything to necessarily get calories out of the body, but sometimes it's more about, I mean, it is illogical in that way. And then sometimes it's also just more about that feeling of emptiness. Sometimes people want that, or it just relieves the shame and guilt that people have about eating. Compensatory behaviors. So purging is a compensatory behavior, but then there's other types of compensatory behaviors as well. So a compensatory behavior is just anything that someone does to avoid weight gain or to alleviate anxiety around the food that they ate to compensate, right? So exercise is a big one, right? Oh, I ate this, I wasn't supposed to eat that, so I need to work out double the time tomorrow. Pacing around the house and just not being able to sit still and stuff because they ate a big meal, so now they need to burn it off, and they kind of won't sit still and will run around and clean and pace and do whatever they can to like keep their body moving, things like that. Chew and spit is a compensatory behavior, right? Wanting to like enjoy the food without taking in the calories. And insulin misuse. This is one that I actually don't know quite as much about, but particularly with type 1 diabetes, folks will sometimes misuse their insulin to try to lose weight or not gain weight, things like that. And finally, checking behaviors. So tracking steps obsessively and trying to get as many steps in as possible. And if you're running low at the end of the day, you're like running around and pacing, trying to get up to your steps, counting calories, weighing food, weighing self often, right? I've heard of folks like waking up in the middle of the night to weigh themselves to see if it's changed from when they went to bed, things like that. And also just checking self in mirrors compulsively. So those are some examples of checking behaviors. Things can look a little different in boys and men. I mean, it can certainly look the same as it does in anyone else, but there is this sort of bigorexia phenomenon, as it's called. So it's that intense focus on musculature and unrealistic body image goals with muscles. Often involves this like restrictive, joyless diet, right? Where they might eat, the same thing every day, and it's like brown rice, boiled vegetables, and a chicken breast, and that's what they have, for every meal. And it's like there's these like cheat days, which are very normalized, which can kind of be just a planned binge in some ways. Just rigid food rules, it can get to a point where they go out to restaurants with their friends and they can't order off the menu because that's not within their diet that they have for themselves, things like that. So there's just a lot of misinformation and disinformation kind of in men's health and in health in general, of, oh, this food is bad, you shouldn't eat that, things like that. And I just threw in this Batman thing because it just shows how men's body image and like the musculature stuff has changed over the decades. Because if you go back to this 1940s Batman, he's definitely like got big muscles, but it at least is like a body that a human is physically capable of having, right? And then if we get to the 1950s, it's already starting to get kind of ridiculous, right? It's just not attainable, it's not sustainable. And then we get into the 90s and now it's really getting crazy. And then the 2000s, I don't even know if all those muscles on this guy even exists. So there's these really unrealistic standards in the media constantly. So how do we talk to someone about their eating and their body image? It can feel kind of scary because these are topics that can be kind of taboo, and they can feel really personal and they can feel really stigmatized. But honestly, like anything, be straightforward, be calm, be compassionate, show concern if warranted, and show non-judgment, right? So a question I really like is just, how's eating going, right? If I'm working with a patient, regardless of, the reason they've come in, I may have no reason to think they have an eating disorder, but just as a general intake process, I often ask people just, how's eating going? And I think that can be a good door into the topic. It's a nice open-ended question. And sometimes they'll say, oh, not good, and it's just like a perfectly fine, normal diet, right? And sometimes there's some stuff there. Another one is just, how do you feel about your body shape and size? We don't always ask people that, right? But if there's reason to be concerned, I think this is a good question to kind of open the door with that. If there's something going on with someone's eating, I do a 24-hour food recall. So I just say to them, tell me everything you ate from when you woke up yesterday to when you went to bed. And they'll say, oh, I don't know. And I say, well, just try to remember everything and go through the day with them, be really specific and granular, get into portion sizes, right? If they say, oh, I ate a bowl of spaghetti, show me how big with your hands, how big was the bowl of spaghetti? And did you finish it, right? And then you do that and ask them, is that a typical day for you, right? And they might say, no, that was more than usual, or that was less than I usually eat, or something like that. And of course, with any behaviors, we want frequency, intensity, duration, and the purpose of the behavior. So some screening tools that I like, there's the SCOFF questionnaire that's just informal. You just ask the questions. So the SCOFF acronym is for sick, control, 1 stone. It was created in the UK. Fat and food. So do you make yourself vomit or sick because you feel uncomfortably full? Do you worry that you've lost control over how much you eat? Have you recently lost more than 15 pounds in a 3-month period? Do you believe you're fat when others say you are too thin? Would you say that food dominates your life? So they get a point for every yes. 2 or more is kind of cause to do more digging. The Eat 26 is another good one. So I know there's folks coming from lots of different places today, but if you're in the University of Iowa healthcare system, we have the Eat 26 right there in Epic. So it's 26 items. It doesn't take long to do. It asks them about current weight, highest weight, lowest weight. It asks about all different sorts of behaviors and diet stuff, but it's still pretty brief. So you get some good information, and that's kind of a good screening tool to give you an idea of what's going on. So we'll talk about prevention a little bit next. And to be honest with you, a lot of these things are things that happen in the home, not necessarily stuff we can always do or control as I know there's lots of different disciplines here, but these are things we can talk to families about. These are things that we can kind of encourage in our time with folks. So first off, I mean, you need to understand that eating disorders are often an attempt at coping. So coping with what? With a lot of different stuff, right? Can be with trauma, with experiences of discrimination. particularly with restrictive eating disorders, it can be a way of numbing emotions. I hear patients talk about that, about how their emotions feel less intense when they're undernourished. Certainly a way of coping with anxiety about weight and food, with a weight-obsessed world, with traumatic experiences with food, often in the case of ARFID. And with anxiety about the negative consequences of eating. So this is just not an exhaustive list, but they're often an attempt at coping. And for some people, even the brain responds differently to food. So as we talked about a little bit already, anorexia does have a strong genetic component. And there's like brain imaging with folks with anorexia, where some of them, their brain literally responds differently. They don't get the same like dopamine reward from food that most people do. So it's easy for them to restrict, right? Things like that. So learning healthier ways of coping is a good initial prevention strategy. So when we're talking about eating, one really important thing is to resist moralizing food. So if you ask me, there's no such thing as good or bad food, right? I don't believe in good or bad foods. Bad foods are things that you're allergic to, right? Like things that are expired and could hurt you, right? There's nothing bad about ice cream. Ice cream's delicious, and it's a wonderful part of a balanced diet, right? So really just resisting labeling foods as good or bad or as healthy or unhealthy, right? The world is just not that dichotomous that foods are just healthy or unhealthy. It's just more complex than that, right? If I ate nothing but ice cream every day for a week, I would feel like crap. But also, if I ate nothing but lettuce all day for a week, I would feel like crap, right? So it's just not that simple, right? We need nice, balanced diets where we're eating foods that we enjoy and that give us diverse nutrition and things like that. So this is a really, really important one. Intuitive eating is good and is a really good approach that we use with patients. Now, you can't really use this with super restricted folks with like active anorexia because their like hunger and fullness cues are kind of out of whack to the point that they can't totally trust their hunger and fullness cues to give them, you know, an idea of how much they need to eat. But for folks who don't have like active anorexia, or for binge eating disorder, this is good too, where there's a ton of stuff to intuitive eating. This is just one little aspect of it, but the hunger and fullness scale is a good one. So on a scale of like 0 to 10, where 0 is like starving, so hungry, 10 is after like a significant true binge episode. 7 is satisfied, full, but not uncomfortably full. You should be eating to a 7 for most meals. And so kind of gauging where your body's at. And if you're not to a 7, adding in some more things and eating to a 7. When we're talking about parents, don't accommodate the kids' anxiety around food, right? So if a kid is having some worries about the types of foods or the amount of foods, or gaining weight or things like that, don't accommodate that anxiety, right? Be compassionate, validate the valid, right? Say, oh, I know there's a lot of confusing stuff out there. I know the world is mean, but you're going to eat the same stuff that the rest of the family eats, and you got to eat, and it's good to enjoy food, and that's okay, right? So just don't accommodate the eating disorder, essentially, or anxiety that is around food. Validate the valid, but yeah. Resist food rules and judgments, right? So like it's okay to eat after whatever time of night. Just resist like judgments that we have around food and things like that. And eating together as a family is good because and again, we're talking about adolescents a little bit more here in kids, but it's harder to get away with eating disorders when you're kind of all eating together and spending more time together. Certainly kids can be really secretive, and parents sometimes don't even know an eating disorder is going on until it's already developed. But in general, kind of just eating together as a meal or as a family more can be a good prevention strategy. Prevention in terms of body image. So a health at every size approach, if you're not familiar, is just the idea that weight and health are not it's just the idea that weight and health are not the same thing, right? It's not that they're completely unrelated, but they are not the same thing. And it is just a movement that walks back from the intense focus on weight that often happens in our world. So I'm not going to talk about that a ton today just because we don't have time, but it's a really, really helpful approach. Body neutrality is a good one too. So, I mean, we all probably know sort of intuitively what body positivity is, right? It's just the idea that bodies are awesome at every size and beautiful and wonderful, and we're celebrating. And absolutely, that's great. I love body positivity, but still within body positivity is the idea that, well, your body should be beautiful, right? And part of what your body exists for is to be beautiful, and that's important, right? Body neutrality walks back from that, and it's just the idea that like you don't need to look a certain way, right? Your appearance is just one small part of who you are, and my body exists to, you know, enjoy the world and go on walks and laugh with my friends and be in nature and learn things and do things and accomplish things. And my body doesn't exist to like look a certain way, right? So that's kind of body neutrality. There's more to it than that, but that's it's just more of that neutral stance to appearance. Certainly learning effective ways of coping, right? That rather than going to controlling diet and food for coping, learning of more effective ways of coping, honoring hunger cues, physical activity, the place of the motivation of where that comes from. So I always encourage patients that physical activity should not come from a place of weight loss or wanting to change your body shape or size. Physical activity should come from a place of achievement and fun and well-being and social life and things like that. It's great. Physical activity is really good for us. It can help with depression and all sorts of things, but it should be for that well-being, right? Not just to punish our bodies or change the shape or size of our bodies. Responsible social media use is a huge one. Literally, there are entire spaces on the internet that actively encourage eating disorders. And they're not that hard to find, right? Platforms will technically filter them out, but then kids are smart and they have ways of like changing their language to get around filters and things like that. So kind of being aware of social media use, asking questions to kids about their social media use and what they're seeing on social media, and things like that. And finally, bibliotherapy. I put a link in here because there is, I think you should be able to see this, but Eating Recovery Center here has an amazing list of different books and bibliotherapy. Like there's workbooks all around body image and eating disorders. So some of them are more like body image focused and some of them are more eating focused, but it's a good resource. Okay. Moving on. So some of the earlier intervention pieces. So diagnosis is in itself an intervention, right? Sometimes folks, I know not everyone here diagnoses, but sometimes there can be this caution of like, well, I don't know if I want to give them that label or diagnose them, right? But if they meet the criteria, don't be afraid to diagnose an eating disorder. The earlier it's caught, the better. And the earlier they get help for the eating disorder, the better. So the way that we have that conversation with them and deliver that information, there's good and bad ways to do it. But in general, if they meet the criteria, then they should be diagnosed. So earlier interventions in working with patients and their families. Again, we talked about this one a little bit already, but kind of often parents have gotten to a point where they're kind of doing a lot of accommodating the eating disorder. It's like, well, she starts crying when I try to get her to eat pizza, so I give her something else. And we kind of have to kind of push back against that and say, okay, the pizza's not going to hurt her, right? Like you can validate the valid, you can comfort her, but she needs to be eating the pizza, right? And kind of helping parents understand we don't want to be accommodating the eating disorder. We want to push up against it and actively fight against it. If anorexia is happening and the kid's losing weight and not getting enough intake, then they shouldn't be doing physical activity. So if they need to, be pulled out of volleyball because they're losing weight, then that sucks for everyone, but that's the situation that we're in, things like that. With purge behaviors, generally what we do is we say, okay, like we're not going to use the bathroom for 2 hours after the meal. We're going to hang out together as a family and do a positive distraction, watch a movie, things like that. But we can, if there's frequent purge behaviors, then it's warranted to put those things in place. Removing things from the home, like laxatives, scales, food scales, smartwatches, calorie counting apps, things like that. So kind of starting to clear out some of those things. And finally, the social media cleanout that we talked about as well. So those are some kind of early intervention pieces that if the eating disorder is diagnosed and they're like waiting to get into a higher level of care, those are some things you can kind of start to put in place. I think that psychoeducation is an important early intervention thing too. So people rarely understand the significant medical impact that the eating disorder can have on their bodies. And it's not like I hate for it to sound like a scared straight thing because that's not the intention, but they do need to know this. They need to know the serious medical consequences that could be happening as a result of the eating disorder. So, if untreated, restrictive eating disorders can lead to death, heart attack, infertility. That one is one that often really scares people. Permanent loss of bone density, damage to major organs, stunted growth, things like that, and more. With purging, similar consequences, but also different ones. So cancers of the mouth and throat, tooth decay, long-term gastrointestinal issues. I mean, you can do long-term damage to your gastrointestinal organs. Other things, stomach, esophagus, mouth ulcers, things like that. So this is just, I think, information that family and patients need to have to kind of start to work on some of their decision making of getting into treatment and kind of beginning to work on the eating disorder. Another thing here is kind of helping set folks up with the team. So eating disorders really take an interdisciplinary approach. Like I absolutely cannot and would not ever want to do this on my own. They need to be seeing a medical professional regularly. It depends on the level of severity, right? So for some folks, it might not need to be nearly as often, but they do need to be set up with a medical provider that they can see regularly. They need a dietitian as well, right? I love being able to work with an interdisciplinary team on this. So they're complex diagnoses and they need multiple disciplines involved. So referral in itself is also an intervention. It is a big deal to get someone into the care that they need and to do it in a way that is like a warm handoff, as they always say, is really powerful. The patient, the family, they're going to be afraid, they're going to be blaming themselves, they're going to have questions. So just being able to work with them can be really powerful, and that's a big intervention in itself. So don't discount that. So we're going to talk about some referral sources here and just some referral process stuff. So eating disorder care is kind of a whole beast of its own. There's some different levels of care. So outpatient care is what it sounds like, right? It's outpatient therapy generally like once a week, or if someone's like in the later stages of recovery, or it's just a very early or very minor eating disorder, might need to be less than a week, or every other week or something like that. But yeah, about therapy generally about once a week, medical provider regularly, and dietitian regularly as needed. Intensive outpatient treatment, at that level, they're generally seeing their therapist regularly, medical professional, dietitian, but they're also in group therapy generally too, and maybe seeing individual therapists more than once a week as well. So different inpatient or intensive outpatient treatments look differently. They're all a little bit differently, but at that point, we're getting into like multiple hours of service a week and multiple hours of like formal treatment toward recovery a week. Next is partial hospitalization. So we have a partial hospitalization program here. It's also sometimes called day treatment. This is kind of like more business hours. So, for example, our PHP is 8 a.m. to 3 p.m. Monday through Friday. And that's, I think, similar to what most of them are. But, they go home evenings and weekends. They are expected to manage those meals on their own. And it includes all the same things, right? Individual therapy, group therapy, lots of group therapy, actually, medical, dietitian, occupational therapy, recreational therapy, different stuff like that. So they generally will have about 2 meals in the support of the program per day. So breakfast and lunch. I think there are programs too where it's more of a kind of a shifted to be more in the evenings, but most of them are like during the day. So that's like pretty much a full-time job, PHP. Residential is what it sounds like, right? They live at the treatment center for a period of weeks or months, depending on their needs, and get all the same things we've already been talking about. And then inpatient is like medical hospitalization more, so it's more medically focused, right? Certainly they're getting medical care in residential, but in inpatient, it really is like a medical setting. So there's some of the different levels of care. So determining level of care is tricky, and it's nothing that I do alone, because often the biggest factor is medical stability. That's certainly not the only thing that goes into it. There's a lot of different factors to consider, but medical stability is one of the big ones. So there's some kind of rule in and rule out criteria. Different programs have different rule in and rule out criteria. So, I can't like lay out, here's what you want to see for these different levels of care, because different physicians at different places, right? They're going to kind of make their own decisions as teams and things like that. And there's a lot of different factors to consider. But medical stability is a big one. Frequency of symptoms, certainly. I heard one time that like a good rule of thumb is kind of like the frequency of behaviors. So like, for example, with purging, that the frequency of behaviors should match the frequency of treatment per week. And that kind of stuck in my head. So like purging only once per week, probably okay with the outpatient therapy, just once per week. If you're purging 3 times a week, maybe individual outpatient, or sorry, intensive outpatient, right? Things like that. Kind of a rule of thumb that kind of stuck in my mind, but again, it's also not quite that simple. Level of like motivation, insight, ability, and willingness to work on the eating disorder is a big one, right? Because if someone, it's like maybe not quite so severe, but they're just completely unmotivated, outpatient might not be the best fit for them because they're not going to be in a position to do that work outside of therapy. So something a little bit more intensive might be a better fit. Certainly level of intake is a big one, like how much food are they actually getting in and keeping down generally. Lots of programs have like admission criteria based on like percentage of current weight. So like dietitians usually make this determination where it's like they look at growth charts and see where someone's body would naturally land, and then kind of calculate where their current body weight is based on that natural weight. And that can kind of be a way that those decisions are made. Co-occurring disorders, certainly, as well as the recovery environment, right? If someone has like no support and they're doing this all on their own, it's going to be a lot harder and they might do better in a higher level of care. But if they have a really supportive, like if I'm working with an adolescent and they have parents who are totally on board and like really motivated, that's a different situation, right? So they might be able to do some of that at a lower level of care. And finally, unfortunately, financial factors, insurance coverage, things like that are going to come into play. Some places are covered by insurance, different insurance companies than others, and it can get complicated. So that's something that we always have to consider too, unfortunately. Finally, just be aware that stepping down and stepping up are common through levels of care. So you start someone in outpatient and say, okay, we're not making the progress that we wanted to make. You're still losing weight. I really think you need a higher level of care. That's okay. Then we do that. However, it's better to err on the side of like caution, I would say. I would rather have someone at the higher level of care that can be justified rather than the lower level of care, because eating disorders are tough and you got to be aggressive with them. So talk about some referral sources. So the Eating Disorder Coalition of Iowa has a provider directory. So it's up here. If you go to provider listings, outpatient providers, there's a big list. This is therapists and dietitians generally, but it's a nice long list, and this is like vetted. So this is vetted by the Eating Disorder Coalition of Iowa. And then there's also a treatment facilities one that is a little bit more generic, but it kind of shows you like ones more in the area. More local resources. So we do have, this is our outpatient, our partial hospitalization program, our website here. So if you have patients that you want to refer, this is a good place to start, and can never guarantee that a patient's going to be appropriate for partial, but this is a good place to start. And we have amazing staff who work with that referral process. If we're thinking a University of Iowa student, which may not be relevant to most of you here, but the University of Iowa Student Health, so the University Counseling Service and Student Health Services actually provide really awesome eating disorder care. It is that more like lower level of severity, of course, but we are really lucky that right on campus for our university students, we have some pretty strong eating disorder care. So if you're thinking of a university student, that's a good resource. The Scanlon Center for School Mental Health also has just started doing some outpatient eating disorder care. So they can see any K through 12 student in the state, I believe. Coffee, you can correct me on that later if I'm wrong, but they had just started doing some eating disorder services as well. So 2-hour diagnostic evaluation and feedback session, and if appropriate for individual outpatient, can provide that as well. So those are really good local resources to be aware of. And then there's just a lot of, if we're thinking more like broadly, there's a lot of really good provider directories through different organizations. So the National Alliance for Eating Disorder, really easy. You can look for a practitioner or a treatment center. I'm not going to go through all this right now, but like this is a really awesome resource. Here's another one, eatingdisorderhope.com. So some of these will have, like, in terms of the like higher levels of care, it may be kind of repetitive that a lot of these databases are going to like have the same places, but in terms of like the more individual providers, it's worth to check out a couple of them to like find out someone in your area and things like that. So this is ANAD, so provider directory there as well. NEDA is the national, an eating disorder association. You have a nice map, right? And the Academy for Eating Disorders as well. So you can get pretty granular with it and what you're looking for, different therapies, comorbid conditions, languages, payment options is huge, things like that. So lots of great options for finding care. Yeah, so that is the presentation. We have just a couple of minutes left for questions. So
Yes.
thank you all for your attention.
Oh, thank you so much. And we'll dive right into questions. We had several good questions come in. Let's start with what is the rate of success for treatment of eating disorders?
A good question. So here's what I'll say. Most people do get better. I don't have like the exact number in my mind at the moment. But I think it's like 60% or something. That being said, and it's going to differ based on like, you know, evidence-based practice you're using and things like that, on a lot of different factors, duration of illness, things like that. But what I will say is that it like relapse is a really common part of it. And for most people, recovery means multiple kind of episodes of relapse before they get to like a stable place with it. So it's kind of hard to determine from that place too. But it can be a years long process for sure. So I don't have the exact number of like how many recover versus how many don't, but most do.
Okay, thank you. And there was a couple questions about the slides and the resources. And yes, we will be sending out a handout of the slides so that you can have access to the links and resources Dr. Kahnke shared. Let's go to what do you do? There are a couple questions around resistance to therapy and how you broach that situation.
Yeah. Well, it totally depends, right? Because if you're working with like a minor or an adolescent, I do some of the work that I do is family-based treatment, which I really don't need the adolescent on board for that. I'm really working with the parents and coaching the parents to essentially treat the eating disorder at home. So if we're talking to adolescents or children, we don't totally need them on board. Yeah. If we're talking with adults, I think, motivational interviewing, right? I think sometimes folks are just not in the place where they're ready yet. But motivational interviewing is always kind of a good approach to talk about the different ways that the eating disorder has taken away from their lives, the things that are maintaining it, their level of motivation to change, what would life look like without the eating disorder. I think, there's always that like don't work harder than your client thing, and just kind of like be curious with them, go at their pace. End of the day, we can't force anyone to do anything that we can't do. But I think that sort of motivational interviewing and that sort of patient, non-judgmental stance can get you a long way.
Okay, thank you. Okay, we'll try to do one more. Can you talk about the correlation with avoidant restrictive eating and eating disorders?
Yeah. So I guess I'm not sure exactly what the question's asking, but
like, is there a relationship or is a history of avoidant restrictive eating correlate with development?
Gotcha. Okay, so avoidant restrictive food intake disorder is it's diagnostically different, right? Because it's not body image based. So from that sense, it's kind of falls into a little bit of a different camp, right, than some other things we talk about, right? Anorexia and bulimia are often the big ones, whereas ARFID is not body image based. I've certainly seen cases where like something might start out with ARFID and then the body image might end up coming into play. I've seen diagnostically complex cases where like it's really unclear if it's ARFID or anorexia, and if the patient's denying that they have body image issues, but like I think there's something there. I can't say for sure what the numbers are of like someone who has ARFID earlier in life and whether they're more likely to have an eating disorder later in life. What my sort of educated guess would be that like a lot of the things that they have to learn to kind of work on ARFID, right? Just managing fear around food, exposure, just getting comfortable with weight restoration, managing fear about the negative consequences of eating, managing physical discomfort with eating, things like that. Those are all really great things that would transfer well to preventing other kinds of eating disorders. So again, I don't have that like those like exact numbers or things, but those are just kind of some of my thoughts on it, I guess.
Okay, thank you. Well, we are approaching 1 o'clock, and so we'll close with a couple housekeeping announcements. The University of Iowa Carver College of Medicine is jointly accredited to provide continuing education for physicians, nurses, social workers, and physician associates. All other participants will receive a certificate of participation. Attendees are eligible to claim continuing education by completing the evaluation and downloading their certificate of participation. I did upload the instructions to claim credit in that chat section, but I'll also send that in the follow-up email. And with that, and if you have any questions, please feel free to reach out to me at Kafi, Kafi-Dixon at uiowa.edu. And I just want to thank you again, Dr. Kahnke, for a very informative presentation, and thank you all for attending. Have a great afternoon.
Thank you.